Thank you for the introduction, and my co-authors and I would like to thank the Arthroscopy Association of North America for allowing us to present our research today. So we're going to talk about outcomes of periacetabular osteotomy with concomitant arthroscopy for the treatment of developmental dysplasia of the hip. This was a minimum 5-year follow-up study. Here's a list of disclosures, none of which are relevant to this talk. So a little background, so periacetabular osteotomy has had good long-term results with survivorship over 60% for 20 years. There's been a high prevalence, however, of intra-articular pathology which may lead to postoperative pain in this patient population. Therefore, the concept of concomitant hip arthroscopy as an adjunct to periacetabular osteotomy was sought to determine if it was a complementary tool. So what are the advantages of doing both procedures at the same time? The advantage is that you can perform a diagnostic arthroscopy of the entire hip joint. You can treat pathology of labral tears, femoroacetabular impingement, subspine impingement, and iliopsoas impingement. Disadvantages, however, it's a steep learning curve, requires meticulous technique. The patient is under hip traction for a period of time during the arthroscopic portion of the case. There can be fluid extravasation, which may make the open approach more difficult. And of course, there's lack of long-term follow-up on both procedures being done simultaneously. So the purpose of this study was to report outcomes of concomitant hip arthroscopy followed by PAO to treat acetabular dysplasia and intra-articular pathology. This is a minimum 5-year follow-up. Hypothesis was that both procedures done the same day for the treatment of dysplasia would result in favorable outcomes at 5 years. So data was retrospectively reviewed and from prospectively collected database from 2010 to 2012. Inclusion criteria included all patients that underwent both the hip arthroscopy and PAO portion of the case, and the patients had to have a 5-year follow-up with the 4 patient-reported outcome measures listed. This included a modified Harris hip score, the non-arthritic hip score, the hip outcome score sport-specific subscale, and the VAS analog scale for pain. We excluded patients that underwent reverse PAO. So dysplasia was defined as an LCA measured less than 18 degrees on the AP pelvis view, and borderline dysplasia was defined as anywhere between 19 and 25 degrees of the LCA. So seen here, our surgical technique includes arthroscopic surgery, which may include either a labral repair or a labral reconstruction. In this video, you can see a circumferential labral reconstruction being completed utilizing the knotless pull-through technique, which we have helped pioneer at the American Hip Institute. In the next video, an incision is then made with the patient re-prepped and draped in a supine position. You can see the approach to the PAO. This is evidence of ischial osteotomy being done, which is one of the osteotomy cuts performed during the PAO. Here you can see a cut to the iliac wing. And next you can see the reduction and drill bit placement followed by reduction screws placed after the PAO is completed. And finally, we choose in our method to perform any capsular management, whether it be a closure or plication, at the end of the PAO portion of the case, as seen in this last clip. Here you can see preoperative as well as postoperative imaging. So results of our study, we had 16 patients that were enrolled, mostly female, age mean of 23.5 years, BMI 24.3, and follow-up time was 66.4 months. The LCEA measurements were significantly different from pre-op to post-operatively, as well as the alpha angle measurement, meaning that there was work done both in the PAO setting as well as in a femoroplasty setting for patients that had cam lesions. Additionally, we found significant improvement in patient-reported outcomes in the 3 measures that are listed in the top graph in the top chart. But the more important finding was, were patients maintaining improvements? So from baseline, meaning preoperative levels, to 2 years post-op, we found significant improvement in PROs. But the question we wanted to ask was, were those improvements durable? Were they maintained between the 2 and 5 year mark? And the bottom chart shows that they were. There were no significant differences between the 2 and 5 year postoperative PROs. And that can be seen in this graph here, between the 2 and 5 year mark. So, in discussion, the concomitant hip arthroscopy and PAO procedure appears to be safe. There's been shown to be significant improvement in the patient-reported outcome measures from baseline to 2 year, and durability, and now 5 year. The visualization arthroscopically allows us to have more accurate diagnosis and information needed to treat the hip joint as a whole. So looking at the literature, there are a few studies that have been reporting on this in 2016 and 2018, but again, more studies need to be shown to show long-term data and long-term outcomes. Limitations: it's a non-randomized study. There's a lack of a control group, and we had a small patient sample size. So the question remains: does the concomitant procedure of hip arthroscopy and PAO make a substantial clinical difference? And that's yet to be seen. So in conclusion, the concomitant procedure of hip arthroscopy and PAO appears to be safe, an effective procedure with favorable midterm outcomes that are durable compared to the short term. Thank you for your time.